So, where to start? So maybe starting with, I'm not really sure if the picture that was just painted was necessarily rosy or optimistic. So maybe I'd just like to get a feel for how people are doing. When you think about the possibilities, the likelihood of having new therapies that will help people with celiac disease available in the near future, and we can define that vaguely. Are we feeling, as a community, optimistic? Who's optimistic? Can we raise our hands? Okay. Who's sort of just unsure? And who's pretty pessimistic? All right. So we got about equal amounts of optimistic and pessimistic, and most people, I think, legitimately and probably most rationally, just aren't really sure where we stand right now. And I think that's fair, right? We've had a number of therapies that looked very, very promising, have some pretty high-profile stumbles, right? And I think Nexvax was the most recent one, which we all know about. And I think where I might start is just reminding us that no one learns to run the first time they, from crawling to running in one step. The failures are really, to call them failures, I think, does not do justice to how much we've learned with each single trial that we've conducted in celiac disease. The celiac disease, it's a small but tight community, not only of researchers and academics, but of people like Francisco and Jack, who you'll hear about in a second, who are really working on therapies. And with every time we do a trial, we learn how to do trials better. And so no participants' sort of altruistic work, time, sort of effort in a trial has been wasted. And we are doing trials in a much different and much more sophisticated way than we were 5 years ago. So I think while it would all have been great if we hit a home run the first time, that really wasn't realistic. And I think it's easy to sort of oversell because we want people to do these trials. But in reality, this is what happens. And I think this is a healthy process. And I think, personally, I am more on the optimistic side that the next couple of trials will get us where we need to go because we've had the experiences of the ALBA therapeutics and of the other groups, chemocentrics and alvines that have come before and really shown us the path forward. And that's also been done through a lot of really great collaborative work with the NIH, which wasn't there in the beginning, but coming back to them again and again, you really get into a much more collaborative problem-solving relationship with regulatory authorities. So I actually think that this is a very, very exciting time in celiac disease. We have tools for understanding the immunology that were non-existent a few years ago, let alone in the things that we just were beginning to use but weren't that well scalable, things we just couldn't do. Now we can understand on a cellular level what's happening in celiac disease, and it's really transforming the way we think about all autoimmune disease. And I do think celiac disease will be the model for not just treating, but curing autoimmune diseases in the future. And this was something that we talked about a little bit in the break with somebody whose child has type 1 diabetes. I think the celiac model will apply across the board because we're learning that these same populations of cells affect people across all sorts of autoimmune disorders with systemic sclerosis, rheumatoid arthritis, type 1 diabetes. There's a very similar immune malfunction. If we learn how to turn it off in one, we can learn how to turn it off in another. And I think celiac disease is the model for doing that. But I can't really do this any more justice than Francisco did. We cannot do this just with industry, just with academic groups. We need government support. So I think we have a very bright future and a very nice path ahead of us if we keep our foot on the gas and if the efforts that the CDF and others are doing to bring in government funding are successful. Then I think we really have a path forward and we have great momentum and great science backing this up. And we have new tools. I think one of the most exciting new tools is the gluten-gnostics tool. Francisco, if anything, was a little too humble, as always, about how important that tool for testing gluten in patients really is. I think this is one of since tissue transglutaminase, TTG antibodies, this is the most important tool that we've gotten in the clinic in celiac disease since, I guess, the late 90s when that came around. Because it's the first time we can really say, all right, you're getting exposed to gluten and you're not. And so you have symptoms, but you're not getting exposed to gluten, so maybe it's something else. Maybe it's irritable bowel syndrome. Maybe it's microscopic colitis. Maybe it's reflux, who knows. You're having symptoms and you're getting exposed to gluten. And so this is why, and so we can treat you and actually have a hope of making you better and clarifying sort of who we can really have the best treatment benefit from. I'm using this personally in clinic. I also don't do any clinical trials without it because I think it's such an important test. and one that I think will become increasingly widespread in the coming years. And all of that, again, comes out of just good government-funded research. So what else do I want to talk about? We've talked about how celiac disease is a lever for intervening on many other autoimmune diseases. I also think many immunologists outside of celiac disease are beginning to realize this in a way they haven't before. And some of the biggest groups in immunology now are starting to work in celiac disease, but they are being hampered by the lack of government funding. And so they're still working in other diseases that are much less easy to characterize, but really starting to sort of say, hey, we'd love to work in celiac disease. Can you help us get grants to really study the underlying mechanisms of celiac disease? So I think there's this groundswell of interest in even the basic and translational science community that really this is a sort of a golden opportunity to take advantage of, and we may miss if we wait too long, because they'll move on and focus on other diseases. And once you get started, and once you're as a young graduate student or whatever, you start your trajectory in one disease, it's very hard to switch pathways. So it's really the timing couldn't be better for this. The other question that I think we're starting to begin to have some ability to tease apart, and this came up a little bit in the questions before, is we know that different people respond differently to gluten. I think you all know that intuitively because different people have different symptoms. We also know immunologically some different people respond differently. We've learned this from our gluten challenge studies. Some people you can put on 2 weeks or 10 weeks of gluten, fair amount, a couple pieces of bread a day, and nothing seems to happen. And it can take months and months of gluten exposure before you get any intestinal damage. Other people can get crumbs and they get severe intestinal damage. That is a huge unanswered question. And that probably drives a lot of who may need additional therapies, because if crumbs make you very sick, dietary avoidance is never going to be enough. If you can eat slices of bread and nothing really happens for months, you probably can get away with diet very easily. And you're probably honestly being stricter than you need to. And so individualizing the gluten-free diet and individualizing other therapies that can be added on to gluten-free diet for the people for whom that makes sense are really critical questions that I think would help everyone, would help us in the clinic, would help us to develop research. But these are things that really can only be done through large consortiums and government-funded studies, because these are sort of fundamental questions in celiac disease. One of the other things is that celiac disease has traditionally been an area where the US has been behind. I think we all know that. EU has been ahead of us from the very beginning. They discovered gluten-free diet. They really got ahead of us. We've actually catapulted in some ways, especially in the therapeutic development in the United States. But we really have the ability, I think, to sort of take over and really lead in celiac disease. And why is that important? Does it really matter whether Europe or US is ahead? I think what Ed alluded to earlier is in some of those quality of life studies. Living with celiac disease, living with a gluten-free diet is different in Europe and the United States. It's probably different in Australia than it is here. So if we try to just apply lessons from Europe to the United States, it's not going to be a good fit, right? You need to, and this is the same reason people should sign up for clinical trials. If people that are not like you are in the clinical trials, it's much less likely that those results will apply to you. The best thing you can do to make sure that whatever therapy or whatever new diagnostic test is actually going to work for you is to be in that clinical trial, because then we'll have actual data on how that performs in you and people like you. And maybe that's your kids, and maybe that's family members. But again, it's the same. I don't think this is something that we can continue, as we've done for a few decades now, to let Europe lead on. I really think the US, if we're going to impact the lives of people with celiac disease in the US, we need to do this research ourselves. We need to understand much better the natural history from birth to getting celiac disease, to looking at long-term outcomes of celiac disease, figuring out who's at risk for complications and who's at lower risk for complications, and really then applying that to treatment. The same way we do for every other disorder, right? We don't treat everyone with inflammatory bowel disease the same. We look at how severe the inflammation is, whether they have a fistula, whether they have a stricture, and then we treat accordingly, right? We need to get to that level in celiac disease. And those are the type of long-term longitudinal studies that really you can only do through government support and sort of the traditional research funding.